We are live in 5, 4, 3, 2, 1. We are live now.
Good evening, everyone. Welcome to this ASSI NSI collaborative webinar on cervical spine trauma. This is done as a part of ASSI Con 2024, and it's a part of the global outreach in which different societies are collaborating with ASSI, and definitely Neurological Society of India, representing the neurosurgeons of the country, is collaborating in this important session on cervical spine trauma. And we have the expert spine faculty from India will be collaborating and talking in this session. So the format is we will have 4 talks by the experts first, and followed by an interactive case discussion. We have from NSI Dr. Shashank Kale, who is the professor and head of neurosurgery at AIIMS New Delhi, who is currently the treasurer of NSI. From ASSI, we have the past president, Dr. Shankar Acharya, will be joining anytime soon, and Dr. Bharat Dave. And from the Bombay Spine Society, the representative, Mr. Alok Sharma. And I'll be moderating the session along with my colleague, Dr. Kanwaljeet Garg and Kshitij Chaudhary from Mumbai. So we straight away will like to welcome all the faculty, and this is and thank you NSI for accepting this kind invitation, and I hope that this will be useful to the delegates. This will be live stream to YouTube as well as on Ortho TV, so a lot of viewership worldwide, and this will be simultaneously recorded and being played during the ASSI global session, which will be happening in Mumbai next month. So welcome all, and we start with Dr. Shashank Kale on odontoid fractures. Welcome, sir.
Okay. Now, can you hear me? Can you see me?
Yes, sir. Yes, sir.
Okay, so I'm going to start sharing my screen straight away.
Sir, can we request all the participants to turn their audio on mute mode? We are getting some interference. Thank you. It's better now, sir.
Okay, is there still interference?
No, it's better now, sir.
Okay. Okay. I'm just trying to get my presentation started. Yes, it is on. Let me share screen first. Share screen. Desktop. Share. Okay, can you see my screen now?
Yes, sir. Yes, sir.
You can? Okay. Okay, so how do I... Okay, so the topic for today for me is odontoid fractures, technical tips and complication avoidance. So for a spine surgeon, whether he's a neurosurgeon or orthopedic surgeon, after a few years into practice, I think odontoid fracture is one of the simple surgeries which can be done very quickly and it has very good results as far as the patient is concerned. I mean, the fracture is fixed, the mobility is restored, and there is practically no need of any orthosis or collar or fusion. I mean, the only fusion which happens is at the fracture site. So it is a gratifying operation. And once you have learned it, it's a relatively easy, fast, and a simple operation. So here is an example on the screen. A typical example of a odontoid fracture. Usually, a young person getting a fracture of the odontoid because of maybe a road traffic accident or a fall or some kind of injury to the neck. That's how these fractures usually occur. And the way to fix it is here is an example. The fixation is, how can I get all these things away?
In the view, like you can go in the view.
Yeah, I can see all the faces here, and half the screen is full of that.
In the top right corner. Then you can choose standard, or you can choose side-by-side speaker.
Hide
Yep.
video panel. Yeah, I think, yeah, that's better. So it's all gone. So here is the operative shots, X-rays, and pictures of the, I think it is the O-arm, which show very clearly how you put an odontoid screw. And if you see the image on the extreme left, I don't know if you can see my screen. Can you see my arrow on the
So
screen?
yes, we can see.
Okay, so you can see the screw is approximately in the center of the odontoid process, so which is a very well placed screw. And if you see the image in the middle, the top, it is the top of the screw, or the tip of the screw is engaging the cortex on the top. And if you see the lower image in the middle panel, the beginning of the hole, or the entry hole, or the screw head rests in the disc space between 2 and 3. And here is the X-ray image of the same, I think, which shows all these three things: the top engaging the cortex, the head of the screw nestling inside the disc space of C2-3, and the screw lying roughly in the center of the odontoid process, at least near the fracture line. So that will give you a very good result and good fixation. Okay. So here's another example. But here, if you can see, the screw is slightly protruding out. If you see the middle panel, the screw is not very well placed inside the C2-3 disc space. It is engaging the upper cortex though, and it is roughly in the middle of the odontoid process where the fracture line is. On the extreme right X-ray, you can see that the top of the screw is engaging the cortex on the other side. So engaging the cortex is an important thing. As we go along this presentation, we will learn how important it is. Okay, so if one has to look at the complications and one does a literature search, here's one paper which I looked at, a review of complications associated with fusion surgery in the craniocervical region. They compared complications of all kinds of surgeries. So odontoid fixation was also one of them. And they compared these few series. And in this, you see that screw cut through is one of the common complications. The screw cuts through the odontoid process. So this happens when it doesn't lie in the middle or approximate middle of the odontoid process. If that doesn't happen, then the screw is going to cut through. The other complications, if you see, commonly discussed are dysphagia and finally non-union. Non-union you will come to know only after a couple of months or maybe 3 months, when you realize that, okay, it's not fused or something has happened, the screw has cut through. Well, dysphagia is almost immediate. I mean, the moment the patient is conscious, he has difficulty in swallowing. And usually that is associated with the approach, where you have to move away the esophagus and the trachea. Try and be in the midline as much as possible. You have to be start and remain in the midline till the end of the operation. So it involves retraction of the trachea esophagus, and that's what leads to dysphagia. So you see, these are the most common complications discussed in the published literature. So this set me thinking, and we looked at our own complications. We studied about 142 patients of odontoid fracture between the years 2008 and 14. All of them done at one center, that is All India Institute of Medical Sciences. And we tried to see what happened to our patients, all these 142 patients. So before we go to the details of what we actually saw, let me tell you the number of operations out of those 142 patients, what happened to which operation was performed on how many patients. So there were some patients, 57 in number, who actually had a posterior fixation operation. So they did not have odontoid screw fixation at all. And now we'll get to that, why so many people had a posterior only surgery and not an odontoid screw fixation, which is a much simpler operation than the posterior fixation. And out of the posterior fixation, these were the various operations which were performed. Magel's technique, that is C1, C2 transarticular fixation. Goel-Harm's technique, where you actually put pedicle screws and a rod, or titanium cable with a bone graft. Some of them had a transoral odontoectomy with occipital cervical fixation, and some only had an occipital cervical fixation, etc., etc. So if you see, the maximum number had either Goel-Harm's technique, that is the C1 lateral mass, and the C2 pars. And Magel's technique is the second most common posterior operation. So the anterior fixation, that is the odontoid screw fixation, the number was 85. And the complications which we encountered are listed here. If you see, the maximum percentage is 3.5% fixation failure, that it actually did not fuse. And this compares very well with the posterior fixation rates, in which out of 57, 2 there was fixation failure. So almost comparable, the same. And the other complications which we saw during our anterior fixation, that is odontoid screw fixation, were screw revision. We had to revise the screw for malposition. One of the screws was malpositioned. The K-wire broke. Dysphagia. Surprisingly, we saw very little dysphagia, only in one patient. Wound complications, overall morbidity, perioperative mortality. Now, this perioperative mortality is a surprising and a disturbing thing, because usually you do not expect any mortality in this operation. It's a relatively safe and a simple operation. However, I will discuss that case individually, why we had that mortality. Non-union in 4 out of the 80 patients which we had for follow-up. At 3 months, out of these 80, 73 had fused in 3 months. And some of them showed delayed union. Overall, except for 4, all the 80 patients who came for follow-up fused very well, the anterior odontoid screw fixation. So you can see it was a very useful procedure as far as the patients treated at All India Institute are concerned. Now, what I've done here is, after 14, 2 more years data has been included. And then we had a number of 111 patients who had an odontoid screw fixation between the years 2008 and 2016. And then I looked at the complications which we had amongst these 111 patients. And you see dysphagia 1.8, K-wire breakage, malposition, non-union, redo surgery in 6.3. Mortality, again, that one patient which was there in the earlier part of the data as well, is the same patient over here. And an overall failure of 8.1%. So still 92% patients fused very well and did well after this odontoid fusion surgery. So here is an example. One of the cases, one of the complications which happened, the K-wire breakage. You can see that very well on the X-ray picture over here. There is a piece of K-wire which is lying Probably it has gone beyond the fracture line and it is lying in the distal part of the odontoid process. However, it is just a little piece of wire. It's a K wire. Now, what to do? How do you tackle this problem once the K wire breaks? Well, we had two options. One was that we could forget about it, just leave it where it is, and abandon the operation and do a posterior fixation. Second was to try and, we would have had to drill away bone and try and catch hold of this K wire and pull it out. But that would have made a big hole in the C2, and the C2 would have been totally useless for an anterior fusion procedure. Or the third option was to try and negotiate a screw adjacent to this broken K wire piece. And I think that's what was done. As you can see over here, we tried to put another K wire alongside the broken piece in a different angle, which has been described when you want to put two screws in the odontoid side by side. That's the trajectory we took for the second time, and that's how we put a screw adjacent to the broken K wire, and we managed to get that. The angle of this odontoid is not perfect. It is not touching the top of the tip of the odontoid process. If you can see over here, it is going through the posterior wall somewhere at the top. However, in the other picture at the bottom panel, you can see the broken K wire and the screw. You can see it quite clearly. However, if you see the head of the screw, it is lying on top of C3. So the size chosen for this screw was not appropriate, obviously. Or the angle at which the screw was meant to go till the top of the odontoid, this screw length was too big for the actual trajectory which was taken. And that's why you can see the head of the screw lying on the C3. So that's not good. That's not ideal. This patient went on to fuse and there weren't many problems, but this is not a correct and optimal operation. So let's get to more cases where we show complications. Here is another patient, odontoid screw. Now, on the right-hand side, you see one of our enthusiastic young colleagues had tried to fix this with an odontoid screw. And promptly, I think this failed. The screw cut through. It came out. And we had to revise this surgery. Now, why did the screw cut through? Two reasons. If you see, forget the CT scan. Nowadays, everything is available. Even a CT scan is available. But this is an old X-ray. I don't know whether the CT scan was looked at carefully. But if you see the X-ray, you can see that this is not a simple C2 fracture, typical odontoid fracture. This is a type 3 fracture. It's not a type 2 fracture. You can see a fracture line going down into the body of C2. So this makes it a type 3. So, you're trying to push the envelope. You're trying to say, okay, if I can get those two big pieces together, maybe they'll fuse this and that, but it doesn't work that way because the trajectory of the screw is such that this kind of a fracture, a type 3 fracture, is not going to work. Just going back to the CT scan, another important concept which you must remember, if you see this picture over here, the top right hand, this fracture line runs into the joint. Can you see that? I hope everybody can appreciate that. So whenever you have a fracture line going through the joint, your anterior odontoid screw is going to fail. It's going to fail because the joints are not stable. And when the joints are unstable, a midline screw in the odontoid process is not going to hold. It's going to come off. So you must look at the CT scan X-ray very carefully, very, very carefully, and see for fracture lines. You can, whether it is type 3, whether it is going up to the joint. And if it is, then your anterior odontoid screw choice is a wrong choice, wrong operation. So this was the reason why this screw cut through over here. Now, another screw failure. So finally, this is the same patient where the screw failed, and finally we had to do a posterior fixation, a Magel's procedure, C1, C2 transarticular screw fixation. And this worked very well. A follow-up CT scan after 3 months showed stable, and the odontoid fracture had fused. Another case, similar case, anterior odontoid screw was put and it failed, cut through in the post-operative period. Now, this was what the final solution for this patient. He had to undergo posterior fixation. Again, a Magel's, a C1, C2 transarticular, and a midline bone graft with sublaminar cable. Now, another important point over here, if you see what has happened is that the fracture is not reduced perfectly. Now, one of the sine qua nons of odontoid screw fixation is the reduction has to be perfect. The alignment has to be perfect. If it is not, this is what happens. You put a screw when the alignment is not proper, it is just going to push the piece further away or pull it, or it will going to spoil the alignment even further. And if the alignment is not good, even after your engagement of the top cortex over here, you can see the cortical bone has been reached. However, it still fails. So you have to be very careful to see that the alignment of the fracture, the two pieces are perfectly aligned. If not, if they're not coming close together, that means two things. One, either there's something stuck between the two pieces, maybe a piece of ligament, some soft tissue, or it's an old fracture. Any fracture more than 3 months and the two pieces have been far apart, it's not going to come close together. You're going to, even if you try anterior procedure, you have to go right up to the fracture, clear off all the soft tissue over there, use a scraper, use something, use a osteotome or something to scrape off the two fracture ends so that fresh bone is available for fusion. Because if you don't clear off all the soft tissue, the two pieces are never going to touch each other and it's not going to fuse. And if it doesn't fuse, all screws are going to break and come out. Okay, let's go further. So this was finally the solution for this patient. Now, another example, 25-year-old male, a bike accident, type 2 fracture. Looks pretty straightforward. But look what happened. The screw cut through. If you see the X-ray on the left-hand side, you can see where the screw is. It's come completely out of the body of C2. It's probably still engaged the odontoid process distally, but it has stopped engaging the C2. So it's a useless screw. It is not doing anything. In fact, it's lying outside in the soft tissue, which can give rise to other problems. So you have to do revision surgery. So again, we did the same thing, removal of odontoid screw, C1, C2 transarticular screw, again, C1, C2 wiring and fusion. So this went on to get infected. His implant got infected. So we had to remove the implants, wait till everything healed. And finally, the surgery had to be redone after the infection was healed. So he had to lie down in bed and wait till the infection cleared. And we could not compromise with his stability, because without any fusion, it was difficult to let him sit up and stand and walk. So that little unplanned or careless surgery, if I may say so, led to all these problems and 3 surgeries to the patient and few months in the hospital. So that's what happens. So another case I'm going to discuss, pediatric case, a 7-year-old child. Now this fracture looks straightforward, right? Well, it looked straightforward to the surgeon. He started in the right place. But you see what's wrong over here? The K-wire has gone way beyond. It's gone way beyond the odontoid process. And this is the shot captured somewhere in the middle. It's quite possible that the K-wire actually went quite a lot inside. In a child, the bones are soft, the cortical margins of the bone are not very hard, and it's very easy for the K-wire to suddenly slip inside. And look what happened to this child when this was discovered. rather, this was not noticed or ignored during surgery. And when the surgery was over, we could not wake up the child. The top of the screw looks all right. It's maybe a couple of millimeters beyond the odontoid, but the bottom of the screw, look at the head. It's lying on C3. Again, the wrong size chosen. However, the operation was completed. The patient was reversed, but didn't wake up. And when he didn't wake up, we got a CT scan done. And look what had happened. The K wire had gone and hit some vessel inside the circle, near the circle of Willis, or at least subarachnoid, and it had led to a massive subarachnoid hemorrhage. And this kind of hemorrhage in a 7-year-old child who's under GA, you don't know what is happening. Unfortunately, it led to a mortality. And this was that one patient who died because of an anterior odontoid screw operation. So you have to be extremely careful, especially in children, when you're putting this K-wire and guiding the screw over the K-wire. The K-wire should not slip at all. You need excellent clamps right near the base of C2 so that the K-wire doesn't move even a millimeter beyond, because the bones are soft and it is very easy for it to go up. So we put together all our pediatric and adolescent cases and got them together and published. So in more or less okay results, except for this one mortality. But we learned from that the clamping of the K wire while you're putting the screw and guiding the screw above it has to be meticulously done. And in fact, you have to measure it, mark it, and make sure put a clamp or something over it so that it never goes beyond that point. You measure the length of the C2 from the tip of the odontoid to the base, and that much of K-wire should be marked or taped, or somehow you prevent any further ingress of the K-wire beyond that point. So finally, I'll discuss one more case. This was he fell from roof 2 days ago somewhere in the mountains. It took him 2 days to reach Delhi. It's a long time ago. I think almost 20 years ago I must have operated, and I've shown this case many times since 2000. Anyway, so this was the his X-ray. On the left, you can see the X-ray, odontoid fracture, clear cut. On traction, reduced completely, no problems here. But before this traction was applied, the CT scan was also done. And you can see 2 images of the CT scan. I've just chosen 2. It was a whole 2 films of CT scans. So this was overlooked because it had reduced completely. I was the surgeon. I mean, I am to blame here. I thought that, okay, this is fine. It has reduced completely. However, I didn't pay attention to this CT scan. Now look at these images carefully. What now, looking back, and hindsight is always 20/20, I can see right away that the transverse ligament is probably disrupted. The amount of movement, the C2 and the facets and the piece of odontoid, the amount of movement which has happened, I'm not very sure that. In fact, I'm sure that the transverse ligament must have been damaged. Otherwise, it doesn't move so much, which I missed. So I put in a screw. You can see the bottom X-ray that the odontoid screw is there. However, there is also that posterior fixation which you see. You see the bone graft and the cable. So why is it there? Because between these 2 operations, I realized that I've done a mistake. And if the transverse ligament is ruptured, this screw is not going to hold. So I turned the patient over, and in the same anesthesia, I did this posterior fixation just to make it safe. And then I thought, well, so my mistake, 2 operations, you could have avoided it. And you can see the date on this, 2005. So almost 19 years ago. So you learn from the mistakes. The second problem in this odontoid screw is it is not reaching the top. If you see this screw, it is starting in the disc space. It is starting just below the C2, but the top of the odontoid is not engaging the cortex distally. That is another reason for me to doubt whether it will hold, and another reason for me to do the posterior C1, C2 fixation in the midline again. So, lesson to be learned, look at the transverse ligament, look at the displacement. If the transverse ligament is injured, odontoid screw is not the correct operation. Look at all the screws which are available to you on the table. If it is if your correct size is not available, There's no point doing it. Useless operation if you leave the screw hanging midway. It's useless. So this was the mortality, and the world literature says 0 to 5%. I don't know why they lost their patients. Maybe because of trauma, other trauma. I don't know. But our patient we lost was a child, and it was because of a neurovascular injury which happened when the K wire slipped inside. So that much we could know. So why do these complications occur? All these reasons: elderly patients, stiff spine, suboptimal position, osteoporotic bone, irreducible fracture, more than 2 months injury to operation time. Whenever there is more than 2 months time, the callus has formed, there's some soft tissue there, the two bones are not going, the pieces are not going to come together. Non-engagement of distal cortex. If your screw head doesn't engage the cortex distally in the top of the odontoid, you're not going to get the lag effect. And if the lag effect is not there, it won't pull the two pieces together. So your screw is probably going to fail. Fracture, wrong choice. Wrong choice of patient. Fracture going through the joints, a long oblique fracture line. Type of fracture, the obliquity, whether it is dipping anteriorly or dipping posteriorly, all these things matter. Unstable C1 ring fractures, other fractures in the spine, osteopenia. You have to look at all these things before you decide about odontoid screw fixation. And if your patient is chosen properly, there is no reason why you land up into complications like we did. So what about two screws? One screw fails. What about two screws? We actually looked at our patients, whether it is feasible. Two anterior odontoid screws, can we actually put them? And we did a CT-based morphometric analysis. And we found, I'll just tell you the conclusion, that only 36% of our patients, which we studied, had a C2 big enough or the odontoid big enough to take two screws side by side. However, the interesting thing which we found was that side by side, they may not be feasible, but एक के पीछे एक, आगे पीछे, you can see the image on top. If you put the screws like this, one behind the other, then maybe you can put two odontoid screws. But side by side, it is very difficult. Only 36% of our patient population had odontoid big enough to take two screws side by side. But front and back, maybe you can. We never tried it. Even in our patients, as you saw, 92 to 93% fused very well with a single screw. So personally, I don't believe that you need two screws in the odontoid process. Another variation which has happened is, everything is endoscopic nowadays. Endoscopic anterior odontoid screw fixation, yes, it has been done. We first did a pilot study, cadaveric study some years ago. It can be done, and now it is being done. Endoscopic odontoid screw fixation. So the take-home message is, it's a useful technique in most fresh fractures of odontoid. The transverse ligament should be intact and the reduction should be complete. There is a technical expertise involved. There is a learning curve involved. However, not a very difficult operation to master. Use all imaging available. Please look at everything, CT, X-ray, MRI if you have, look at everything before you decide. O-arm makes the operation safer. It definitely does. Single screw is sufficient, but use the right size. You must engage the top cortex of the odontoid process. Look at the entire cervical spine. You may have missed a fracture. In the enthusiasm of looking at C2, many times you miss lateral mass fractures or other fractures in the subaxial spine, which may lead to a problem later. And if it is an elderly patient, 70, 75 years old, I usually prefer a posterior fixation, because doing this surgery anteriorly, shifting the trachea and all that for 1 or 2 hours, I don't think it is okay. And the posterior fixation works very well. Or if the patient is very old, 85, I would do nothing. Just give him a collar. If there is no neurological deficit, just give him a collar and let there be a pseudoarthrosis. Let it not fuse completely. And many patients have, at least 3 patients I know, where I did not operate at all because they were 80 or 85 years old. And they did very well with that pseudoarthrosis. They lived another few years without getting into neurological issues. Thank you very much for your attention. Any questions? No problem.
Thank you, sir. Thank you for taking us stepwise to what can happen with an anti-odontoid screw and telling us how to avoid such complication. Just a question from the audience about size of the screw and how to decide the length of the screw. So any tips on that?
Yeah. So you can actually measure it. When you put your K-wire, you know how much K-wire has gone inside. So put a clamp there at the base of C2, take it out, measure it. You can easily measure it. Not an issue.
And would you consider decreasing the length of the screw because it will create some lag effect? So maybe 2 mm less than what we measure on the K-wire because it is supposed to create some lag.
Yeah. So as long as you engage the cortex on the distal side, you will get the lag effect. So even if your screw goes 2 millimeters beyond the cortex, it doesn't matter. Usually nothing happens. It looks bad on an X-ray or CT scan, but you're sure that if one thread is outside the odontoid process, at least 10 threads are inside. Then that is what is going to give you that lag effect. So the important thing is, I think, engaging the cortex distally. Rather than short of the tip, I would rather be 1 mm outside the tip.
Yeah. So one question is if the screw is long and is maybe occupying a part of the C3 or so, what is the problem in that? This is one of the questions.
I think the wrong length was chosen. You should measure the K-wire and see that your screw head should actually just touch the end plate of C2. It should reside there, in the disk space between C2 and 3. It should be in the middle. It should not be jutting out of the disk space. It should not be lying on the C3 body. That's too long a screw. So the measurement of the screw, the length has to be perfect. In Indian population, anything from 34 to 38 is usually the correct size. Rarely would you need more than that.
Yeah. Thank you so much, sir. We next invite Dr. Gururaj, who is a senior consultant spine surgeon and unit head at Indian Spinal Injury Center, and who will be talking about unilateral and bilateral facet dislocation. Dr. Guru, you can share the screen.
I would like to thank ASSI and Dr. Sachin for giving me this opportunity. Can you see my screen, Sachin?
Yeah. Yes. Yes.
Okay. And I would ask everyone to actually mute themselves, please. Okay. So my topic today is how to reduce a unilateral and a bilateral facet dislocation. So cervical facet dislocations happen due to mainly osteoligamentous injuries. And the main kind of injury mechanism is flexion distraction, and associated rotation can be there. And C5, C6 is the most commonly affected level. And all the 5 to 10% of the cervical spine injuries have some kind of subluxation or a dislocation. Unifacet dislocation, there is hardly any 25% of translation. And in bilateral facet dislocation, it's around 50 or more than 50% anterior translation will be there. And 82% of the bilateral facet dislocation have a traumatic disc herniation. Why is that important? We will see in our future slides. And 85 to 90% of these injuries have neurologic injuries. Coming to reduction options, which is the topic of today, is closed reduction. That is, you can put a traction on the bedside or on OT table, and open reduction, that is by doing surgery. It can be done anterior, posterior, or a combined approach. So we'll see the closed reduction, which is most commonly attempted in all of our clinical practice settings. Basically, the reduction we want to achieve because it restores the normal spinal alignment. and immediately decompresses the spinal canal by giving a basically a good environment for the spinal cord to improve. Before doing any kind of reduction maneuver, if it is possible, MRI imaging is the imaging of the choice, because it tells you, is there any traumatic disc herniation into the anterior epidural space? If at all it is there, how big is the disc, and whether it is going to matter whether attempting a close reduction without removing the disc is worthwhile or not. Definitely, if there is a dislocation, there is going to be a PLC injury. It is going to show you extent of the PLC injury, whether the PLC injury is only at that level or it is at adjacent levels also, and the amount of spinal cord injury, the amount of the edema into the spinal cord. So that gives you an idea, and other level injuries, if at all they present, because the other level injuries are almost 30% common when you have a fracture dislocations. And timing of the MRI with respect to the reduction is, if MRI is readily available, it is preferably we should be getting it done. And if patient, definitely if it is a neurologically intact, we should do the MRI. And patient is awake and cooperative, and again, we should go ahead and do an MRI. And emergent close reduction is unnecessary. Emergent close reduction is only necessary in progressively deteriorating neurology. So if at all that scenario is not there, we should try to get an MRI done as much as possible. Sometimes we might have to do an MRI in an emergency basis. That is, during close reduction, if at all patient expresses or your neurological examination shows that there is neurological deterioration during the process of reduction, or after the reduction you find that the neurology has deteriorated, you have to do an emergency MRI. Risk of close reduction, as we were already talking, there is a small risk of neurological deterioration, and it can happen due to sudden jerk which happens, or it can happen due to the excessive distraction we put it on during the close reduction, or it can happen due to the traumatic disc herniation which was there before. Sometimes when you reduce these dislocations, the disc can migrate into the epidural space, causing impinging on the cord and cause neurological deterioration. And in 2 to 4% of the patients, it is reported to have a transient deficit. And most of these patients recover after you do surgery and take out the disc out. And permanent deficit happens in only less than 1% of patients. So you can see that such a big traumatic disc herniation can be there, causing cord compression. So definitely in these patients, you cannot do a close reduction. Here you have to do a open reduction. First, you have to go ahead and remove the disc and then do a reduction maneuver. The dilemma is whether to go ahead and do it or not. If you don't have an MRI, definitely there is a possibility that there is a traumatic disc herniation which is causing cord compression. And if patient is not awake or disoriented, then again there's a dilemma whether to do a close reduction or not. The presence of disc herniation, that is a traumatic disc herniation, a mild to moderate one does not preclude you from close reduction. Definitely in a awake and a cooperative patient, where you can stepwise or every increment of the weight, you are going to examine the patient, and patient is going to report to you if there is any change in the neurology. So even if there is a traumatic disc herniation in the MRI, you can go ahead and do a close reduction. So prerequisites, definitely it should be preferably done in an alert and cooperative patient. And in these patients, we should go ahead and do or an environment should allow us to do a continuous neurological assessment. And there has to be a X-ray which is available where after every increase in the weight or after every change in the force applied to the cervical spine, you should be able to do an X-ray, and traction can be applied safely. Before applying any traction, we should be sure that there are no skull fractures. The skull is able to take the weight. There are no diseases which actually make the skull soft, especially in pediatric patients. In terms of monitoring, when we are into the process of doing a close reduction in the ICU or in the ward, there has to be sequential addition of weights. don't suddenly increase the weight, because sometimes you feel you are at 12 kgs and it is not distracted at all. And don't increase from 12 to directly 18. You don't know whether 18 is going to cause an excessive distraction. And distraction is one of the most common injuries which happens during the close reduction maneuver. And serial neurologic and radiographic examination has to be done, as I was telling you. So no neurological deterioration or slightest of change in the neurology should be happening, and no over distraction of the spine. How do we compare whether there is a over distraction or not? We should compare the disc size adjacent to the adjacent levels, and also there has to be just the perching of the facets. It shouldn't be a over jealous distraction of the facet joints or inferior articular process over the superior articular process. So you have to continuously monitor that. And you have to monitor the vitals, because neurogenic shock is very, very common when you're trying to do a close reduction maneuvers. Techniques, definitely pain killers, that is analgesics, will help by decreasing the spasm of the muscles. If you reduce the pain, the spasm will be reduced. You will require lesser amount of weight. You should give anxiolytics. Garden wall strongs well applied symmetrically. If you apply them asymmetrically, then the force applied will be different on both sides, and then there can be a distraction asymmetrical onto the facet joints. Reverse tendon bunch position. Start with 3 to 5 kg weight. Check X-ray has to be done with every increment. 30 degree of flexion you should be able to give, and with every sequential increase, add around 3 to 5 kg of weight. Weights are added to distract the inferior articular process over the superior articular process of the caudal vertebra. Once these facets are distracted to the level where they are perching, extension moment is applied and reduction is achieved. Once you have achieved the reduction, you have to slowly decrease again the weight to retain around 7 to 8 kgs or 5 to 6 kgs of weight, depending upon the level of the injury. Coming to unifacetal dislocation, it's a very tricky job, and most of the times we fail to reduce them by close reduction maneuver until unless we do it in a proper way. So we have to understand that the unilateral facet dislocation is not only a flexion distraction force which has gone into it. There was a flexion distraction with the rotation maneuver. So we need to simulate the force which was dislocated that unilateral facet initially when we apply the weight onto it. That is, the contralateral loading force has to be there, and ipsilaterally cranially directed force has to be there. So once you do that, and then once the facets are perching again, then we have to not only extend the neck, we have to rotate it into the opposite direction. So this again, coming to tips and tricks. Traction applied in 30 degree of flexion. Pins applied 1 centimeter above pinna and 1 centimeter posterior to external auditory meatus. Weight should be increased every 15 to 20 minutes. Don't be in a hurry, because you have to allow the tissues to relax, the ligaments to relax, the muscles to relax. You have to allow the tissues to creep. You can go up to 75 kgs, or you can go up to 1/3 of the body weight of the patient. You have to do a neurological examination with every increment, radiographs, and avoid over distraction. So those are the pictures. You can see the weight is applied in a flexion position, and sequentially weight is increased. You can see the weight are going on increasing, and there is a flexion of 30 degrees onto the neck. And then once the facets are perched, you have to extend now there is an extension has happened at the neck, and the weight has been reduced. So this is how you do it. So the pitfalls of this we already discussed. Weight should be gradually removed. If you remove weight suddenly, then there is a sudden collapse, and then again that also can cause disc herniation. That's one of the examples. C5 C6 bilateral facet dislocation. This is manual close reduction which is being done. So that's how you see, and that's the reduction has been done. And bilateral facet dislocation at C6-7. 6-7 is again a difficult level to reduce, because it's at the junctional level. You need a lot of weight. most of the times we have to go up to 30 kgs of the body, 30 kilos. And you see that facets are perching again, and then reduction is achieved by doing the extension maneuver. So that's anteriorly fixed. So close reduction under anesthesia, there is no advantage. If at all you have decided already doing a surgery, it's better to do a open reduction because you have a more controlled environment when you do a open reduction as compared to a close reduction. So in anesthesia, there is always a higher chance that you over-extract. And if patient is anesthetized, if you're not monitoring, then you will not know whether there is any traumatic disc herniation happening and causing neurological deterioration. Close reduction attempts, there are scenarios. If there is no new neurological deficits, reduce traction, do an MRI and proceed with open reduction. If there is no neurological deterioration, you can, or there was no pre-existing traumatic disc herniation, you can omit doing an MRI. But ideally, after every reduction, MRI has to be done to check whether we need an additional anterior procedure or not. Maximum traction weight achieved. If there is no reduction happening, reduce traction, do MRI, proceed with open reduction. And if reduction achieved, maintain inline traction and plan for stabilization. Coming to open reduction, you can do it in two scenarios. That is basically a rule. If you have just a, without any traumatic disc herniation, you can do only posterior approach, reduce from the posterior approach only. And if MRI is not available, or if you have a traumatic disc herniation, you might have to do only anterior approach or a combined approach. Basic mechanism of distraction and reduction. When you are doing anterior procedure, you have to flex the superior vertebra. That will give you a distraction onto the facet also, and then do an extension maneuver and then have a compression maneuver. So this is a reduction device. You can use a Casper pins. Initially, the pin will go basically from superior to inferior direction, and then you will move the pin from this position to this position so that it gets kyphosed and distracted the posteriorly. And then again from this position, you'll go back to the original position where there is an extension maneuver. So you can use basically the laminar spreaders. Again, if you see the laminar spreader applied from inferior to superior direction so that it distracts. And then when you take it from the inferior to superior position, there is an extension movement happening and it closes the posterior facets there. So in every technique, this movement will apply from inferior to, you take it to a superior position. So again, you can use basically a hook kind of a laminar spreader. So again, you can see the movement happening from inferior to a superior position. You can use your cage distractors or a cage sizers. You can go on increasing the trial sizers, and then again you see the movement which happens is once you have distracted, you have to push the vertebra posteriorly and do an extension maneuver. Same, you can use a pin and a cage distractor, which will allow you more controlled distraction and reduction as compared to using a single instrument. This is again using a pin distractor along with the laminar spreader. You can do the same thing as it was discussed before. Coming to unifacetal dislocation, you can see there is a rotation movement which is there. So you will always not only doing this superior to inferior movement from inferior to superior movement, you will also have to do a rotational movement onto the opposite side. This I have never done. This is from the textbooks again. You can do an anterior facetectomy as shown here in the picture C to decrease the always the scare of doing anterior reduction is without doing any facetectomies, the over distraction which you can do, and already injured cord can get injured more. And especially in cervical spine, if one level also the edema increases from C5, C6, it goes to C4 also, it makes a lot of difference to the patient in terms of weaning from the ventilator, in terms of getting them independent. So the one criticism about anterior only approach of reduction of these facets is over distraction and causing more neurological deficits. So again, the same thing, facetectomy from anteriorly. And coming to the posterior approach, posterior only reduction, you can use 2 towel clips, gently distract them, and then again close. Once they are distracted, you can see under vision, and then you can close them, bring them closer. But then this is again a very crude amount of traction applied is very difficult to measure. It's always better to do this. A curate or a posterior periosteal elevator can be introduced into the dislocated vertebra and slowly elevate that facet out of the dislocation part and leave it to the reduction maneuver. Or vice versa, you can use both, where you can use a gentle force and you need not distract the facets too much. The best approach is this. If I do a posterior approach, always try to take out some part of the superior facet so that the amount of distraction which we apply when I try to reduce this inferior facet onto the superior facet is lesser by decreasing the iatrogenic injury to the spinal cord. So this is one of my favorite methods. And you can use pedicle screws like what we use for basically reduction of the listhesis. So this is one of the case, C67. You can see both anterior and posterior approach was done because there was a huge disc here, and the pedicle screw was used. So the tricky situation arises when they have a delayed presentation, especially when they present after almost like 2 to 3 weeks. So always you have to apply preoperative traction and try to achieve as much as reduction possible. If at all you achieve reduction, then it's again like a similar what we discussed in now. So if there is a disc herniation, you have to do a combined approach. If there is no disc herniation, you can do only posterior approach or only anterior approach. But especially in terms of junctional areas, when you have C6-7 dislocation with facet fractures, it's always better to do a combined approach. When it comes, if it doesn't reduce, if there is no disc herniation, you can go only posteriorly. Again, do some facetectomy and use pedicle screws to reduce that. If there is a disc herniation, you have to go ahead and do first a discectomy, go posteriorly, do facetectomies and reduce, and then fuse, come back and fuse anteriorly. Take home message: urgent close reduction should be attempted, especially when patient is awake and cooperative. MRI is preferably has to be done if at all you are planning for a close reduction, and preferably should be done post reduction also. And urgent MRI is mandatory when you have any neurological changes. Unconscious patient, pre-reduction MRI is must, and urgent open reduction in a failed close reduction and if there is any neurological deterioration. Thank you.
Thank you, Dr. Gururaj, for an excellent, lucid presentation of each of the situations of unilateral and bilateral facet dislocation. There are some questions on this, and we would like you to answer those.
Yeah.
If it is not possible to reduce the facet with distraction, do you plan on 360 going posterior first and drilling to reduce and then go anterior, or it always gets reduced with distraction?
So especially as I was telling, C6-7 dislocations, sometimes they don't reduce. In that case, as I told, most of the times we would have done an MRI. If there is no any traumatic disc herniation which is pre-existing, I do only posterior. And if at all there is a disc herniation, then it will be anterior, posterior, and anterior. So anteriorly, first go ahead and remove the disc, and then go posteriorly, do just a superior part of the superior articular facetectomy, and then reduce the dislocation, fix it posteriorly, come back and do a anterior fusion. So it all depends on whether there is any traumatic disc herniation present or not. And especially the junctional areas, I always tend to do a 360-degree fusion, because we have published a study where we have seen that especially in junctional areas, only anterior fixations tend to fail.
Yeah, another question is actually on whether to do a 360 or an anterior or a posterior only approach. Obviously, many people, many of these patients are quadriplegic or paraplegic depending on the level. And once you achieve a reduction, maybe by an anterior approach, some people just put an anterior graft and cage rather than going posteriorly because the patient is unlikely to walk. So what is your opinion on this? Biomechanically, ideally it should be 360, but at times people just tend to do away with only one approach.
Okay, if it is a pure flexion distraction with only soft tissue injury, and if the dislocation is at 4, 5, and 5, 6, you can just do an anterior fusion with plate fixation. And we all know that cervical fusions usually go through and they fuse. But if at all, if you have a posterior osseous injury, if you have facet fractures, if you have laminar fractures, if you have pedicle fractures, especially in those mechanism where you have an extension distraction injuries, especially where your facets are fractured and it is dislocated, there you need a 360-degree fusion. So you need 360-degree fusion when you have posterior osseous injury and in junctional areas like C6, C7, and where you have done an excessive facetectomy, where you are not able to overlap the facets when you are trying to reduce, and you did a excessive superior articular facetectomy and you are not able to overlap these facets, then also you need to do a 360-degree fusion.
Yeah, thank you so much, Guru.
Thank you.
We now invite Dr. Muthukumar. We will be talking about timing of surgery in cervical spine trauma. Dr. Muthukumar is the past secretary of Neurological Society of India and currently working in Madurai as a senior consultant neurosurgeon.
Thank you, Sachin, and thanks to ASSI for this opportunity. Are you able to see my slide and hear me?
Yes, sir. Yeah. Go ahead.
Once again, thanks to ASSI for this opportunity. And in this presentation, I'm going to talk about the timing of surgery for acute cervical spine trauma, the facts and fallacies. And this presentation is based on the evidence in the literature, does not necessarily represent either my personal preference or my practice pattern. My personal preferences are summarized in the end, which is based on my own experience as well as the evidence in the literature. Now, these are the areas we are going to discuss in this particular presentation. Why is spinal injury important? Why early surgery for spinal cord injury? How early is early? How does one define early? Is the timing of surgery same for all levels of the spinal cord? Is it same for complete spinal cord injury, incomplete spinal cord injury, and acute traumatic central cord syndrome? Is the timing same for patients with spinal cord injury with associated polytrauma? What are the economic consequences of early and late surgery? And finally, the most important issue, is it possible to practice what is being published in the literature? Why is spinal injury important? All of us are aware with the increasing road traffic accidents worldwide, the incidence of spinal cord injury is increasing with the accompanying socio-economic impact. Why should you discuss the timing of surgery at all in spinal cord injury? It is to promote standardization of care and to enable surgeons to make evidence-based informed decisions. And we have to understand that spinal cord injury is not a homogeneous entity. It is heterogeneous in that younger patients tend to suffer from high velocity injuries, whereas older patients tend to have lower velocity injuries like falls in the setting of a pre-existing secondary canal stenosis. And once again, as I mentioned earlier, there are 3 types of spinal cord injury: complete, incomplete, and acute central cord syndrome. All the 3 of which, as all of us know, have different prognostic implications. And we do know the importance of primary and secondary injury. Primary injury is what happens at the time of impact. And this primary injury initiates a sequence of biochemical events, a cascade that aggravates the damage caused by the primary injury. The aim of our treatment is to prevent or alleviate this secondary injury, for there is very little we can do to deal with the primary injury. Why early surgery? There is compelling experimental evidence to suggest that early decompression after spinal cord injury mitigates the effects of secondary injury. And it is widely believed that persistent compression after primary injury is a reversible form of secondary injury. The advantages of early surgery include early mobilization of the patient, which prevents all the complications associated with prolonged recumbency, and also reduce pain and narcotic use. Certainly reduces the complications and length of stay in the hospital and ICU, and possibly even mortality, as we shall be seeing later. The disadvantages are there are logistical issues, as all of us know. It may not be possible in all places to do an early surgery, that too in the middle of the night in suboptimal situations. Or if there are associated injuries, actually early spinal surgery might sometimes aggravate the overall, may cause more harm to the patient. Now, this is something, the bugbear of this topic is that there is, even in 2023, there is no perfect definition of what constitutes early surgery. There are publications which have used 24 hours. Most publications have used 24 hours as a cutoff point, but there are other publications which have used 8 hours, 12 hours, 36 hours, 48 hours, and even 72 hours. So there is no absolute definition of what constitutes an early surgery, as we shall be seeing as we proceed through with this presentation. Now, this is something you cannot talk on this topic without referring to this STASIS trial, which is a prospective multicenter study involving 6 North American centers, where 24 hours was used at the cutoff point. And the primary outcome was the improvement in Asia Impairment Scale, and the secondary outcome was the complication and mortality. Now, this showed when the outcome was assessed as 2 or more grade improvement in AAS, certainly early surgery had an better outcome than late surgery, being the cutoff point being 24 hours. But when the cutoff point was reduced to 1 grade improvement in AAS, there was no difference between early and late surgery. But this is a widely quoted study, but this is not without its pitfalls. This study was not randomized. Therefore, there is a possibility of selection bias. There are several patients which are not enrolled in the study, like the patients with associated head injury and polytrauma, which is not what we encounter in day-to-day practice. And early surgery cohort, if you look into dive deep into the tables, we find that the early surgery cohort had more younger patients, which means they had less associated comorbidities. And the late surgery group had more patients with complete injuries, which means inherently there was a selection bias that led to the possible results. Now, the other limitations being nearly 25% of the patients were lost for follow-up. And the trial was conducted in specialized high-volume centers. How far the results of this trial are applicable to non-high volume centers in peripheral centers is something that needs to be studied. Then we go to the Rick Hansen Spinal Cord Registry, which is a registry based in 31 sites in 15 Canadian cities. This studied 1,400 patients, and they showed that in patients with incomplete spinal cord injury, early surgery is definitely beneficial, but not so in patients with complete spinal cord injuries. This brings us to the next question. Is ultra-early surgery useful? Sorry. There is certainly a scientific basis for ultra-early surgery because ischemia, hemorrhage, and edema reach a peak about 8 hours after spinal cord injury, as per experimental evidence. Therefore, the first 8 hours provide a therapeutic window for prevention of secondary injury. So, if you intervene within the first 8 hours, theoretically, there should be a better outcome. But does it translate into clinical practice? This particular meta-analysis of the literature, which studied 7 studies from 7 nations, used 8 hours as a cutoff point. It included both cervical and thoracolumbar. The outcome was, and the length of hospital stay was certainly better in the 8 hours group, whereas there is no difference between the complication between the 2 groups. Now, this is another study that deals with ultra-early, but please note, unlike the other study, here the ultra-early was defined as less than 12 hours. The patients were divided into 3 groups: ultra-early less than 12 hours, early less than 24 hours, and late more than 24 hours. What these authors found was if the surgery was done within 12 hours, the patients had a better outcome. But after 12 hours, even if it is done within 24 hours, they didn't have a better outcome. And this pertains only to cervical spinal cord injury, which is the topic of today's discussion. Now, what about traumatic central cord syndrome? And traumatic central cord syndrome is the most common form of incomplete spinal cord injury. The incidence ranges from 15 to 25% of all spinal cord injuries. Usually occurs in elderly due to pre-existing spinal canal stenosis due to either CSM or OPLL. This is the AO Spine guidelines published in Global Spine Journal in 2017, where they mentioned there is early decompression is probably preferable in patients with Asia grade C injuries, Whereas in patients with ASSI grade D, late decompression is an option. Is an option with a period of observation because there is a chance for spontaneous improvement. Now, this is another publication, once again from Michael Felling's group. This is published very recently in JAMA in 2022, where 183 patients were matched on the basis of propensity score matching analysis. They used 24 hours as a cutoff point for early surgery, and they found when patients with traumatic central cord syndrome were operated early, the early surgery improved the upper extremity motor score in the ASSI grading scale, but not in the lower extremity motor score. What about this study? This is from a Japanese study, which shows timing of surgery in cervical spinal cord injury without burning injury in the elderly in patients over 65 years of age. Here, 48 hours was used as the cutoff point. And according to this study, in traumatic central cord syndrome, surgery within 48 hours does not show a positive influence on recovery after traumatic central cord syndrome. What about polytrauma? It is important to realize that many patients with spinal injury also have associated polytrauma, 16 to 30%. The incidence ranges anywhere between 16 to 30%. The pros of operating on such a patient with polytrauma is that delaying spine surgery leads to complications associated with recumbency. If you fix the spine, the other conditions like abdominal injury, etc., can be dealt with quickly. The cons is an inappropriately timed spine surgery in the setting of polytrauma leads to increased incidence of hemodynamic instability, causing a second injury. Now, this is a study which was published almost 12 years ago, which showed in a patient with polytrauma with spine trauma, the more than surgery done after 24 hours increases the risk of complications 8-fold, mainly due to recumbency. This is another study published in Journal of Neurosurgery in 2017, where they used 36 hours as a cutoff point on 340 patients with polytrauma with injury severity score of more than 16 was used, and 46 of these 340 had cervical spine injury. They showed that if surgery was delayed, spine fixation was delayed by beyond 36 hours, there was a 29 times increased risk of developing complication. But this study has several limitations in that the early surgery group has 20 years younger than the late surgery group, which means the late surgery group, there is a selection bias in this particular study. That is the reason, that might be one of the reasons why the late surgery group had a delayed more incidence of complications. Now, is there a difference in the outcome between early and late surgery vis-a-vis the level of injury? The guidelines of AO spine published in Global Spine Journal 2017 shows in cervical spine injury, certainly there is some level 2 and level 3 evidence to suggest that early surgery has a better outcome, but it's not so for thoracic and lumbar injuries. Now, what about the time, the complication rate, the length of stay in the ICU in the hospital? Once again, in cervical, the complication rate, early surgery decreases the complication rate, decreases the length of stay in the ICU and the hospital overall, but not so, to a certain extent in thoracic, not so in lumbar injuries. What are the economic implications of the timing of surgery in cervical spinal cord injury? This is one of the recent publications. 1,600 patients were studied. 24 hours was used as the cutoff point. There are two take-home messages from this. The incidence of repeat surgery at the index level was not affected by whether the surgery was done early or late. But late surgery beyond 24 hours was associated with a higher likelihood of discharge at home, lower utilization of OP services without any difference in costs. Now we come to the most important question. Is it possible to practice what we preach or what has been published in the literature? Now look at this publication about 10 years ago from US, where a nationwide inpatient survey was done in US. In US, only 30% of patients with acute traumatic central cord syndrome were able to undergo surgery within 24 hours. Most of them underwent surgery a median of 3 days after trauma. And this is another publication, once again from US, where the data were taken from the National Traumatic Coma Data Bank, 2,600 patients. 1/3 had complete spinal cord injury, 1/3 had incomplete spinal cord injury, 1/3 had central cord syndrome. And it was found even in an advanced country like US, only 44% of patients underwent surgery within the stipulated time frame of 24 hours. Most importantly, majority of the delays were not due to delay in transfer, but delay after admission. The reality of accomplishing surgery within 24 hours for complete cervical spinal cord injury. This is one of the recent publications in Journal of Neurotrauma, where only patients with ASSI grade A injuries with cervical spine injuries were included. 24 hours was used as the cutoff point, and more than 2,800 patients were included from many North American centers. Nearly only less than 2/3 of patients were able to be operated within 24 hours. And it is important to note, it is not the patient characteristic or the level of the trauma center, whether it is level 2, level 1, or level 3, they did not influence the timing of surgery. This is a very important study which I'd like to highlight. Rick Hansen's spinal cord registry. As I mentioned, 31 sites in 15 Canadian cities. This study showed the difference between ideal and actual time, the discrepancy between what surgeons actually wanted to do, but what they were ultimately able to do. This study showed more than 95% of surgeons actually wanted to operate as early as possible. But as far as cervical spinal cord injury was concerned, only 1/3 of the cases they were able to operate within 24 hours. This is the reality in a developed country. Now, good intentions do not always lead to good results. And this is what is shown in the National Inpatient Sample published in 2017 in Spine. Between 2001 and 2012, when early surgery was propagated aggressively, many patients got operated in peripheral hospitals, which actually was associated with increased mortality. Therefore, these authors recommended transfer of this patient to specialized high-volume centers. Now, this is a very important study, once again, from none other than Michael Felling's group. This study I would like to highlight because, unlike all other studies in the literature, where an arbitrary cutoff point like 24 hours or 12 hours or 48 hours was used, this study is different because this used time from injury to surgery as a continuous variable. And they found there's a steep decline in the outcome when the patient was operated after 24 to 36 hours. This is something worth noting because this is probably the only study in the literature where time to surgery was used as a continuous variable. Now I'll just give some examples to show that how in the Indian scenario, or the one-size-fits-all protocols are difficult to practice. This is from my personal experience. Some examples from my personal experience. This is a 45-year-old female with ASSI grade A injury, was operated about 36 hours after injury, and 6 months later, her ASSI grade was B. And this is another 34-year-old female with ASSI grade C on admission. But this patient came to us within 24 hours of injury, within 12 hours of injury, but we were able to operate her only about 24 hours after injury, and 6 months later, she was in ASSI grade E. This is a 19-year-old female who came to us within a few hours of injury. She was ASSI grade E. We wanted to operate this patient under intraoperative neuromonitoring, as a result of which the surgery got delayed by 3 days, and postoperative ASSI grade continued to be E, and she has 7 years follow-up. She is doing well. And this is a 60-year-old male who came with traumatic central cord syndrome, ASSI grade B on admission. For various reasons, this patient also got admitted within 24 hours of surgery because of the associated comorbidities. We delayed surgery for 5 days. We did a 360-degree fusion and decompression, and 4 months later, he was an ASSI grade D. And this is my personal preference, which is based on the literature and practical logistics in the Indian situation. I would personally prefer to do surgery as early as possible in the patient with incomplete spinal cord injury, whereas in a patient with complete spinal cord injury, early surgery certainly theoretically is preferable, but it should be recommended, but need not be. I do not do it in the middle of the night if the patient is a ASSI grade A at the time of admission. In patients with normal neurology, I would prefer to do surgery under neuromonitoring. Therefore, it will be done only as an elective case. So the key takeaway messages are, there is at least now level 2 or level 3 evidence to suggest early surgery is better than late for cervical injuries, especially for incomplete spinal cord injuries. And time is fine for incomplete. The concept of time is fine is true for incomplete cervical level injuries, not probably for thoracic, not for lumbar injuries. And most of the studies in the literature are affected by the fact they use only ASSI motor score for outcome. It's time we start looking at other outcome measures like minimally important difference and other parameters like functional independent measures, which will be used as a parameter, outcome parameter in future studies. This will enable us to identify so the subsets of patients who will benefit from early surgery, so that the limited resources that are available in resource-constrained countries like ours can be utilized for the benefit of patients who have a greater chance of improving. Thank you for your kind attention.
Thank you, sir, for an extensive review and summarizing a complex topic into simple one for our audience. Just a question from my side. If it's a Asia C incomplete neurology coming to you in the evening, would you do it in the middle of the night, or you would wait for the next available OT in the routine slot?
I would like to do it as an early morning case, not in the middle of the night, because logistically there are practical issues. When many of the patients, I think this might apply for other centers as well, because what happens is that even if the patient comes to us within 24 hours, counseling takes time. Patients in our situation have unrealistic expectations, and they expect the patient to, or the relatives expect the patients to become absolutely normal post-operatively. We cannot give such guarantees. So it takes time for the patient, counseling the patients. That is what takes most of our time, not any other factor. But certainly I would not take such a patient with incomplete spinal cord injury at 2 a.m., 3 a.m. I would like to do it as the first case in the morning.
Yeah. Thank you so much, sir. One question from the audience is, do you decide to operate a patient with neurogenic shock, or do you wait for the shock to settle?
I would. It's extremely difficult for me to differentiate between a neurogenic shock and a true spinal cord injury. I would assume it is a true spinal cord injury, and if there is a persistent ongoing compression, it should be relieved as soon as possible. Logistically, if there's a persistent ongoing compression on the spinal cord, as visualized by imaging, and if it is possible for us to operate, it should be done as early as possible.
And a favorite question on steroids? Do you use it?
I don't give it anymore. I used to. I've done it for 15 years or maybe even more than that. Not anymore. Because at least as far as my knowledge goes, the 2013 CNS guidelines clearly mentions that there's no role for methylprednisolone.
Yeah. Thank you so much, sir. We next move to Dr. JKBC Parthiban. We'll be talking about cervicothoracic junction fractures. Obviously, it's a very tricky region. Dr. Parthiban is in Coimbatore, neurosurgeon at Coimbatore, and a very senior member of the neurosurgical spine community.
Thank you. And are you able to see my slides?
Yes, sir.
Thank you, Dr. Sachin, giving this opportunity to speak on this complex situation, cervicothoracic junction fractures, decision makings, and the problems. Now, this picture clearly shows a few excellent one that you can see. This is the T1 and T2, then we have the C6 and C7. So look at this here, you see the manubrium, important thing, and the lordosis very nicely seen in this picture on the lateral aspect, and we see the diagrammatic picture here. The manubrium corresponds to T1, somewhere T1 in normal adults, but it is not the same everywhere. So the cervicothoracic junction, we cannot call it as one is C7 and then it transfers from C7 to T1 to include C6 as a functional unit in biomechanical sense, and T1, T2 does not move much at all. So we can call it between C6 to T2. Why this is much important is because it is a transition zone, as I said, from a mobile cervical spine to the rigid thoracic spine. And anatomically, if you see, it is from a soft surrounding to a much bony region. And there is a wider spaces at the cervical spine, and slowly closed down, becomes narrow at the neck and enters into the thorax. Those areas are having a very narrow space. Hence, they have a relatively easier neighbors at the neck, but more complex neighbors at the thoracic opening there. And so, for a surgeon, it is from an reasonably easy, accessible to a challenging space. It also embeds in another system. For example, that cervical spine, no problem, but then respiratory system is important. There is a significant variability in anatomical structure for all of us and human beings. So all these points to be taken up when we start looking at the importance of the cervicothoracic junction injuries. The principle of surgical decision may be more or less the same for the subaxial cervical spine, but that can be challenged by other factors. Like I said about a thoracic injury, clavicular injury, an injury at the upper thoracic region associated, and also, of course, other multifactorial injuries. So the surgeons may have to change their approach at that point of time. So one need to be well trained. Very clearly, I'm telling this point, one need to be very well trained and experienced to attempt this area. I would prefer a teamwork in this particular specialization. When I show my slides, you can see that. Now, this is what I was talking to you about here. This is the way it is a thoracic is in the thoracic cavity. The spine enters. You can see that the large vessels are crowded here. In this region, the large vessels are absolutely crowded, and you find the lung over there. And so these injuries at this region is going to be pretty much complex than what you think. Now, when we approach the cervical spine at C4, C5, and C5, C6, it's absolutely simple because you have a beautiful fascial, interfascial, and areas where you just relax it goes. But when it narrows down to the cervical, C7, C6, C7, and T1, it becomes pretty tight. Unless the anesthesia is very good, it is impossible to retract the trachea and also the esophagus. So that makes the surgery more complex. And you must be very careful in dissecting at this region. And so the experience is important. So I would particularly say that young surgeons do not do this without specialists or the senior surgeons. I'm very, very clear about this. The why reason is because the amount of complications you can produce on these regions, if you try to attempt without experience, is very high. Now you can see here a distraction fracture subluxation, very looking very bad. C6, C7 fracture, both the anterior elements and posterior elements are broken, and it is absolutely unstable. And you can see this is the patient when he came. Amazingly, this patient was neurologically stable. Can you imagine this? Amazingly, this patient had a clinically intact neurology. And this is the time when we put the patient on retraction first. And you find there is hardly much reduction, but there are a lot of fractures over the facet also. But finally, the traction has made a good reduction here. And then we went ahead from anteriorly and did an anterior instrumentation in this case. I do not use a large amount of kilograms of weight. I don't remember using more than 10 kg or 12. I don't remember even using it because my techniques are different. And I'm talking about with 30 years of experience in this, because the larger the traction you put, it is not comfortable. And when the patient is in anesthesia, and actually we do not need that much of weight. What you need is a little bit of weight to reduce this kind of cases. But I was very happy that this got reduced and we were able to do it. We call this as junctional. I doubtful because the clavicle over here, and we have a beautiful space here. And this is another case you can see here. This patient again C6, C7 dislocation with locked and purged facets. Purged facets here. These are the 3D reconstructions. You can see most of the cases we do 3D, and then this material is seen there. Almost in all the cases, majority of the cases, I try to approach anteriorly, most of the cases. The question is whether to approach anteriorly first or not. It depends upon that how much the perched facet can be reduced. Because C6 and C7 and C7 to T1, it is very difficult to reduce it by weight alone. As my previous speaker was talking about it, his experience has clearly shown that it is very difficult. So it is always better to go ahead with do the discectomy and do some osteophycectomy. While you're doing this, automatically you find that something movement is happening, and with a good anesthesia, you may get a good reduction, and then you can put a plate simply and fix it. Here, if I go back, I'm not able to go back. Yes, I'm able to go back here. If I find where is my manubrium is very low. So this, I don't know whether I can really call this as junctional, but then still, yes, okay, fine, for the discussion's sake. So it is possible to reduce it. Now, this is my Sachin has given me these cases, which his experience shows. These are all the C7 and D1 fracture dislocations. If I look at all these things, they are having a very beautiful space here. So these spaces are much easily, and they can be treated as we do for subaxial cervical spine, and they have done the same thing. So you can see that beautiful fixation. This is a very lovely fixation. And one point here to talk about is the manubrium. So the screws is slightly, you need to have a technical expertise to put this, and you may need a good assistance to help you. In this case, this is AIMS experience. Another case they have done like this, an anterior approach. And you can see that anteriorly the plate is after the reduction is placed here, and then they also have done the posterior for the 360-degree stabilization because it looked more complex. In this case, it's more complex. Now, this is the case which I have done some 25 years ago, not now. And that is the time that this kind of 3D CTs were available, not like what we see now. You can see here there is a facet dislocation, and it was very facet dislocation. This is the pre-op, and the pre-op anterior and posterior will not able to reduce this. So I have to go posteriorly first. I usually do I do not yank. I have to just do the superior half of the posterior facet, just trim it down. It automatically reduces with the weight. So I do this lateral mass fixations. You can see this, they are reconstruction plates. You can judge why it is 25 years old. You may not have, nobody may have been seeing this type of plates now. Now these were the reconstruction plates which we used those days on the lateral masses, and then turn the patient to do the 360 degrees because it is a much complex injury. So we did the anterior fixation. So this is a 360-degree for C6 and C7 perched. And then this is the present generation, new generation places. Now here you can see that another C7 T1 which was not coming out of traction. You can see this facet joint is pushed up very high, not reducing it. Then the first stage, I went behind and did the facetectomy. This MRI was done, and there's not much of a disc prolapse. So I went behind from posteriorly, facet drilling reduction with the lateral mass and also the facet screws, and then turn the patient anteriorly and fix the anterior plate. This is a very simple plate I used. Here, there was some technical challenge because the angulation was too much. But however, I had a space here. You can see the manubrium here. You can see the manubrium. I had some space here. I could able to negotiate and put the anterior screws very safely. Now, this is very important. As far as the junctional areas is concerned, whenever I find the C7 is above the manubrium, and I'm absolutely fine. C6, C7, no problem. The complexity comes when there's C7 and T1, and then you have to find out where your eye look at the thoracic spine. Usually it's about T1 or T2. When in a long neck patients, you can find it is high rating T1, T2 go above, so it is much easier. But if it is not so, then you must change your approach, because most of the cases, as we do in the cervical spine, we do anterior, right? But in some cases, we have to go posteriorly. But in the junctional areas, quite often you may have to go posteriorly. Now, if you have an anterior compression here, above the clavicle and manubrium, you can always go anteriorly. But in this place, it is very difficult. That is why it is important to see the manubrium notch. And in the lateral X-rays or lateral CT scans or MRI, so you have to do a very, very lavish and good investigation, not limited investigation. I have limitation, then we should not attempt this area for surgery because it is very complex. You can see here, this is how we may have to open this area. It looks pretty complex because of the large veins and this, and you have the aorta coming in this region, and then you have the subclavian vessels going on. You may have to retract it. The left side is much easier than the right side. You all know about because of the recurrent laryngeals. So I would suggest that whenever you see the manubrial notch, you must be very careful. But if your approach, you need to go down here for T2 or T3, then you may have to swing out this manubrium. This manubrium along with the clavicle up to the second costal, you can always swing it out from one side. And there are so many techniques. The first mid-thoracic approach was done by us in 1992 in Cochin, and it was published in Neurology India in 95. And then later on, we started this Sundaration technique. And now we do the open door method and then close it up. So this is very important. So I will show you some cases on which came recently. I had this bulky lady. You can see this so bulky lady. You can see here. She had a C6, C7, a disc prolapse, but at the same time, there is a dislocation here. I was surprised. I asked this patient because she was having a progressively weakness. And then when we put the manubrial channel, you can see the notch here. It was pretty tight and it was so big. I had no choice how I'm going to do. Even if I do a discectomy, how will I fix it up? Because I don't think that it is very difficult. You may have to put an angulated screw over here, or you have to come back and do a posterior fixation. However, I did this approach, and you can see that's cervicothoracic approach, and then this is the area of interest. This is our area of interest, and this is just like the simple, no, right? You do as you do for your anterior cervical discectomy in the plate and the screws, and this is the large vessel. You can see that. You can see very well. The retractors are very simple retractors. You don't need to put very difficult retractors. And here you can see very well. It is so close. This is the first rib. You can see the first rib, and so these screws are difficult to put if you don't have a good approach. So you can see a very nicely placed anterior implant. So you all must be very clear with this presentation that now when you want to approach anteriorly and your area of interest is falling below the manubrium, then you need to sweep the manubrium. And if it is in a thick neck patients, short patients, thick neck patients, an injury, it is not the same ball. Please understand that the trauma is very, very unforgiving in this region because of the large vessels and the esophagus in a tight situation. The lung is not good. You will have a torrential post-operative problems. So these are some of my other cases. You can see here the same approach, manubrium clavicle approach, and this is the area of interest. And this is the corpectomy of one of the cases in the corpectomy. And then you put the cage in those days. And these are all very old patients. I do not remember. I just don't remember the timing of this, but this was done long time ago. This is another patient. You can see here. Now you can see this particular implant. This implant is such a long implant. It is going into the depth because you are approaching inner cavity, which from the lordosis to kyphosis. Lordosis to kyphosis means what you see at the cervical region, at the thoracic region, you may not see that. That's why you need microsurgery. You must use microscopes or very high illumination, good light, and the angulation. You must have a very good assistant. You must have a very good assistant to do this type of surgery. Now you can see this. These are all done long years ago. So I like to conclude my talk by saying that cervicothoracic junction injuries are pretty complex. As far as I'm concerned, if the manubrium and the clavicle are very low down, thin neck, absolutely no problem. But thick neck, short neck, and you have you are not able to even see the C7 or C6. Pretty be careful and try to get involved your thoracic friends to help you in this field. Thank you very much for this opportunity, Sachin. Thank you.
Yeah, thank you, sir. Thank you so much. You already answered that if you have the access surgeon, which I think some of the audience had questioned that if do we need to take help of a cardiac surgeon for this exposure? So obviously, if you have the facility, you should take because you do not routinely expose this area. The other thing at times, sir, and the question is also that many a times putting the distal screw, maybe in T2, is tricky because you cannot see it on proper X-ray, or X-ray doesn't show it well. So are there any tips for that? This is question by one of the delegates.
Yeah, see, I tell you, initially those days, we never had the advanced CT scans. Now we have. Now today we can do a CT angiography and you find the relations of your vessels. For putting the lower one, the only thing is angulation. Most of the time, what you need to protect your arch of aorta, which comes there with a nice retractor. You saw that retractor, which is this is a retractor, but then I always put a nice cotton pad, sponges, which will protect. So the retraction, believe me, you can always push those vessels down. You can always, all these things I learned from my thoracic friends. Now, the reason is, though I can do myself, but I still want them because, in case of any complication, you have no clue what to do, particularly this. So, distal screw, if you put, you have to try that. Now, you must also see the angulation before going into the theater. So that point is very important. That is why I said that MRI and also the CT scan, and you try to draw the line and see. And if you have a CT angiogram done, now you can do it because of the availability of the technology. So it is always better. And adding this access surgeon, I can say rather than access surgeon, these surgeons are very essential for us for postoperative care also. Because, laryngeal spasm is pretty common. So we can always do a tracheostomy with laryngeal spasm. So I always take my thoracic surgeon along with that, though I always like that. I have to do that even if it's there because they are very good. Believe me, I still had one experience with a thymus, a big thymus. Everything is done dissection, then you find this fellow is coming and popping on in front of you like we get the thyroid. If the thyroid is very big, when you go for C5, C6, you find the thyroid is very big. But here the thymus, in that case we had thymus, and this gentleman said, no problem. He did a thymectomy and went ahead. So there you need to have a thoracic surgeon.
Yeah, completely agree, sir. Thank you so much, sir. We have overshot, but it was a very good discussion for all during all the 4 talks. So I will ask my colleague, Dr. Kanwaljeet, to present 1 or 2 short cases for discussion, which we already, so that will be good. If Dr. Shankar Acharya is there, he can also please join for the discussion. And all the faculty can contribute to the cases. Yeah. Kanwaljeet, you can share.
Thank you, sir, for giving me this opportunity. Is my screen visible?
Yes, go ahead.
So without further ado, I'll start with the case presentation. This was a 56-year-old male who was an auto rickshaw driver. He was driving auto rickshaw, was hit by a truck from behind. So he was brought to our trauma center emergency department. His GCS was 15/15. His neurological examination was ASSI below the level of C7. Over the next half an hour, his respiration was compromised and he had to be intubated. He also required inotropic support. This is his cervical spine X-ray, which was done in the trauma center ED. As we can see, the X-ray is not very clear. I'll move on to CT, which was done in the emergency department. Here we can see that there is bamboo spine and there is fusion of the lateral muscles on both the sides. And essentially it's ankylosing spondylitis with the extension distraction type of injury. And this is the coronal section showing the fracture gap. Its MRI was done from the ED itself. They had placed, as we can see in the CT, the fracture was very much distracted in extension, and while MRI they tried to flex the neck, but that was not enough given the kyphosis of the patient. And we can see that there is impingement of the C7 lamina over the spinal cord. So the diagnosis of this patient was a B3 and 4M3 type of injury, which is a hyperextension tension band injury with incomplete cord injury, with complete cord injury with modifier of ankylosing spondylitis. His slick score was 7. So the dilemmas which we faced were, is there any role of traction in this patient? May I ask one of the moderators to shed some light on the role of traction in such patients?
So, Dr. Parthiban, would you like to answer this? Yeah, Dr. Parthiban probably is not audible. Dr. Gururaj, what's your opinion about traction in such cases?
Definitely. You said it's incomplete or complete?
Complete. It's complete.
It's a complete injury now. So definitely, see, these are especially this kind of ankylosed patients. Applying traction in an awake patient is really difficult because it gets locked in that position, and to get them to a kyphosed position under traction is really difficult. Definitely, I would apply a traction, but after anesthesia, under monitoring, under anesthesia, not awake traction in ward, because there can be a ward distraction. These patients suddenly can go into a respiratory depression, and we have to be careful because in these patients, the other soft tissue injuries can also happen. You can have ruptures. You can have major vessel injuries when you apply traction. You can have basically a thoracic duct injuries in these patients. So it's very important that we should apply traction in a very controlled environment, and operation theater is the best environment where we can apply traction in these patients.
Yeah, I agree with you that traction can be very counterproductive in such patients, and it has to be applied in very controlled environment. So the next question was the timing of the next question was whether this patient should be operated or not. So as this is a 3-column injury, unstable injury, I think that patient should be given a chance of surgery to stabilize the spine. So though patient is Asia A, we don't expect much recovery in this patient. Dr. Sachin, do you agree with this, or do you have some other thoughts?
Yeah, obviously it's a very highly unstable injury, so it should be fixed, and we hope for the best for the neurological recovery. And obviously, I think a circumferential fixation will be what will be my plan.
Yeah, I'll come to that. So what about the timing of the surgery? Like this patient comes to the ED in the afternoon, let's say. patient is on ventilator, patient is on inotropic support. By 7 p.m., you have got the MRI and CT of this patient done. Would you take up the patient in the middle of the night, or would you like?
No, I won't rush. I will stabilize the patient, and as means I will do an early surgery, but after stabilizing, maybe the next morning OT in a reasonably controlled condition. Because these patients have problem right from positioning, and there are so many challenges in this case that I believe that should be done only during routine hours, because they have all other issues, and positioning, etc., are pretty tricky at times. The positions are quite abnormal, and you have to work in some difficult areas, in a difficult positions in such cases. So routine hours, yeah.
Dr. Guru, you have a comment to make?
Basically, see, in these patients, what we have to understand is ankylosing spondylitis or a 3-column injury in a fused spine is totally different as compared to other normal spines, because the secondary cascade or a secondary injury to the cord is the greatest here. So in a routine non-fused spine, whatever injury happens at the time of injury. But then in ankylosing spondylitis, the majority of the injury happens after the injury has happened, not at the time of the injury, and because the ongoing compression and the highest amount of instability which is present. So the timing of surgery is very, very important in these patients. We should operate on these patients or stabilize this fracture as soon as possible. And I would try to mobilize all my resources, even if it is in the night. I would go ahead and do these surgeries, because the only thing is you need to mobilize your resources. Because if you leave them overnight, or if you leave them for morning, the edema might ascend to C4 and C3, and these patients might not come out of ventilator at all. And these patients have a highest mortality rate. The cervical spine injury in ankylosing spondylitis has a highest mortality rate. So if at all you want to reduce the mortality rate, you need to operate them as soon as possible, even if it is in the night, if you can mobilize your resources.
I think I agree with you both. The issue with these patients is it's not only the spinal fracture which we are dealing. Many of these patients have restricted lung disease, heart arrhythmias. We have to take care of all these things. If the patient is of course stable and we can mobilize our resources, we can do it in the middle of the night. So the next
what I wanted to just convey with my message is that the secondary cord injury is the highest here. We shouldn't relax. We should try to do it as soon as possible. In a normal non-fused spine, if in a ASSI patient, you can delay the surgery for another 2 days, but not in ankylosing spondylitis. You should do as soon as possible. And I will tell you, you won't be able to optimize these patients at all. You won't be able to control their BPs. If you keep them for 4 days also, the BP will keep falling because your compression is ongoing. Until unless you take away the compression, BP is not going to come up. So you cannot optimize these patients. There is some amount of risk involved always, and counseling is very, very important, because even after you do everything, these patients can succumb to all other problems other than spinal cord injury. So you need to take them up with high risk consent and as soon as possible.
Yeah, will taken. So the next question is approach. It will be anterior approach or posterior approach or a combined approach. Dr. Sachin, what do you think about this?
We can have Dr. Kale opine as well.
Okay, can you hear me?
Yes, sir.
Yeah. So traumatic injury in ankh-spond, so it's a dangerous situation. So you need a 360-degree fixation in this. All attempts should be done to get a 360-degree fixation. Unless you don't have the experience or training how to deal with this area. Only then you should settle for one, but you should call for help and try and get a 360-degree fixation in this kind of an unstable spine.
Yes, sir. Yes. So the next question is, which approach should be done first? An anterior approach first or a posterior approach should be done first in this case? Sir, what do you think about this?
Anybody? Dr. Muthukumar, what do you think?
Thank you, Shashank. I think if I remember the MRI correctly, there's a significant compression from the posterior elements, isn't it? The compression is from posterior, not from the anterior disc. Therefore, my approach first will be, it is obviously, as Sachin said, it's going to be 360-degree. My compression is first to relieve the posterior compression and probably stabilize 2 levels above and 2 levels below posteriorly if you are able to achieve an alignment, and then going anteriorly. Because I think by the time they have done the MRI, the alignment is reasonable. Only thing is, we do not know whether the approximation has taken place. And as far as the word traction is concerned, I would say I would certainly apply a Borkar tongs, will not use a traction as such because already there's considerable distraction. And as Gururaj said, that any further traction might aggravate, cause a lot of soft tissue injury. I would rather use the garden tongs to position the patient to bring the spine into alignment. That is about the traction. And as far as the approach is concerned, posterior first, followed by anterior.
And do you think, sir, 2 level above and below will be enough, or you would like to fix more?
I think 2 level above and below, even though this is close to the junctional area, 2 levels above and below should be sufficient. And because we are going to do a 360-degree anyway. Why do you want a more than 2 level? Any specific reason why you want a more than 3 level? More than 2 level?
Sachin, go ahead.
Yeah. No. Actually, what they think that they behave as if it's a long bone fracture because it's a bamboo spine.
Okay.
So longer the construct, better is the stability. This is what means. Even in the anterior approach, some people put long plates with multiple screws encompassing more levels, so that the stability is more. The same logic is for posterior approach. That's why I was just asking.
What I meant was not only 2 levels above and 2 levels below posteriorly, but also anteriorly 2 levels above and 2 levels below posteriorly, provided we are able to approach the anterior exposure is sufficient to give a 2-level exposure below the injury. Provided, I think from the images we see, probably this guy has got a low manubrium stenosis. It should not be a problem to expose posteriorly. I mean anteriorly, 2 levels below.
So what we did the anterior approach first in this patient. I thought that it will be easier for me to align the spine in the kyphotic alignment, which is which was there in this patient originally before trauma, from the front first. And these are the images taken from OT table. Like this was cervicothoracic junction, so we couldn't see anything on X-ray. We used O-arm after positioning the patient to ensure that the fracture is reduced and it's in the natural alignment of the patient. So
Kanwaljeet, is this the natural position of the patient? At times, this is the natural position of the patient, that his head is lying way above the table. At times in Angstpond, it happens that they are in a fixed kyphosis, and you have to no further change in position is possible. So is it the natural position, or is it positioned in such a way to achieve a maximal reduction?
This is the natural position of the patient. Then the patient was not a diagnosed case of AS. So we questioned his family members and they showed that the patient had kyphosis. He was brought down. And this is what. So we did a long segment plate as 2 up, 2 down. It was difficult to reach the fracture, but we could manage a plate 2 level above and 2 level down below of the fracture level, and we used ILCS graft. And then we did 3 level up and 3 level down from the back because the bone was very osteoporotic. These are the
It's 9 o'clock.
Positioning of the patient can be challenging, and we may need C-arm, and we must get an imaging done after positioning the patient, because intraoperatively we might not able to reduce once we have opened it up. And then we should use long cervical plate. ILACS graft has to be preferred. Long segment posterior fixation and longest possible screws should be used because the bones are very weak in these patients. Just I'll quickly.
Yeah, Kanwaljeet, I think that will be enough of one case. One case will be presented by Dr. Raghav, which will be on a higher level injury. So that will complete the session, because it will then would have discussed everything from C2 to C70 even. So anyone has an opinion about how the case was managed? Gururaj, you wanted to say something?
Yeah. I think there was some distraction left at the end, right, Kanwaljeet?
Yeah, there was a distraction from the front which I filled up with the ILACS graft.
Yeah. So that's what I was mentioning, when it's very difficult to approximate these, and especially if you use something like a Doro or something, you can apply some compression also once you reduce. But then when we do this free positioning with the bolsters and all, that becomes really difficult. But then I was surprised you got a good alignment. So very well managed.
Thank you.
Yeah, thank you so much. Dr. Raghav, you can share the second case. A quick 10 minutes.
Yeah, Dr. Sachin, are they visible?
Yeah.
Thank you. Yeah, so moving on quickly, I'll be discussing a 22-year-old female who presented with a road traffic accident. And this was the X-ray that was seen in emergency, following which a CT scan was ordered. And the patient did not have any neurological deficits. On the CT scan, we made a diagnosis of an atypical hangman fracture, where there was a pars fracture on one side, and on the other side, there was an oblique fracture going through the C2 body. There seems to be some amount of displacement, and not much angulation can be seen in this scan. And again, in the axial images, we can see that there is an oblique fracture going through the right side of the C2 body. And on the left side, there is a pars fracture that can be seen. Some displacement, more than 3 mm is seen on the sagittal cut, and a slight bit of angulation. These are the relevant images to that case. We can see on one side, the pars is intact. On the other side, there is a comminuted fracture of the pars. And there is also an oblique fracture line that can be seen. A CT angio was done, and we can see a co-dominant vertebral artery, slightly more dominant on the left side, but no injury, and the normal caliber is there. The MRI images again show that there is no cord compression at any level. The disc seems to be disrupted, and the ALL and PLL also show some amount of damage. Moving on, based on Levine and Edwards classification and the atypical hangman fracture classification, so we reached a diagnosis that this was an atypical hangman fracture, type 2, and atypical hangman type 1, whereas one side pars and oblique through the body. Now I'll get to the next part, which is the part for all the panelists and the elite speakers out here. And the first question I think I'll give to Dr. Sachin himself, that do you think there is a role of pre-op traction in this patient? And would you put it when the patient has presented to you awake, or would you do it in the OT under anesthesia? Any particular precautions with the traction that you would like to take?
Obviously, these are our open injuries, so less chances of neurological compromise. This is actually opening the spinal canal. So we can put a pre-op traction, and the patient is obviously conscious oriented. So if there is any problem, we'll come to know. We'll try to align this fracture in reasonable alignment so that our approach becomes easier. So the surgical planning becomes easier. So this is what I feel I will put up pre-op traction.
Right. So, okay. So we'll put a pre-op traction. And next, moving on to the management option, I think there are a lot of options for various kinds of hangman fracture, and one needs to analyze each fracture individually. So we'll go one by one and see if this is a option for this kind of a fracture. So the number one, I think I'll go to Dr. Kanwaljeet. Would you consider managing this patient, 22-year-old female with an atypical hangman fracture, on a conservative method? Is halo an option for this patient, or it is not an option?
I personally will prefer a fixation in this patient. Halo can be tried, but I think that we are not very sure, given the complexity of the trauma, we are not very sure whether it's going to work or not. And to keep a young patient in a halo for 3 months and after that finding that the fracture has not fused, so it'll be a little awkward situation for me.
Right, absolutely. Right. And with regards to a pure C2 osteosynthesis screw, Dr. Muthukumar, any experience on that, sir? And would you think that would be an option?
I have used pure C2 osteosynthesis in not in this type of fracture. I would say this is a Levin-Edwards type 2A fracture, which is not an ideal case for a pure Judas procedure. That's what some people call this pure osteosynthesis Judas procedure. The Judas procedure I have done in a few patients, not this type 2A, with what is Herbert screws, which the orthopedic surgeons use for scaphoid fractures. And but this particular case, I wouldn't do a osteosynthesis doing a C2 screw. My option will be two options, both of which I have done. Either if I go anteriorly, that depends upon the lateral X-ray of the cervical spine. If the angle of the mandible is at or above C3 body, I would go anteriorly because it will be easy to expose that C2, C3 space and do a C2, C3 anterior cervical discectomy and fusion. And posterior option will be a C1, C3 fusion, which obviously is going to compromise her rotation, which is probably not very great in a young female. But if you have a O-arm, I would do a C2, C3 posterior fusion. I don't have a O-arm, so it will be very difficult for me to, with such a displaced fragment of the pass, it will be difficult for me to pass the screw without O-arm.
Right. So I think you've covered three options. And if you had to choose between one, the anterior alone or the posterior alone, which one would be your choice?
I would go for posterior.
Posterior.
Because at least I have, even though I have done C2, C3 for a few cases of hangman fracture in a young 19-year-old male, I had almost typical, almost similar to this. I did a C2, C3, a beautiful fixation. Next day morning, the post-op X-ray showed wraps of the subluxation and had to take the patient again and do a posterior fixation, which is a very painful experience because patient comes to you without a neurological deficit. And of course, the patient was well preserved, but then doing two surgeries instead of one is not a great option.
Right. Dr. Gururaj, any opinion on this? Would C1, C2, C3 be also one of your choices in this patient? Or you would still try C2, C3 fusion even in the absence of a O-arm? Would you try that first, Dr. Gururaj?
Actually, definitely, you have to, once you position under anesthesia, you have to see what is the amount of distraction. You can do without O-arm the C2, C3 fusion. And typically what I do is, once I pass my screw into the posterior fragment, I lift my the spinous process of the C2 and push it anteriorly to close that gap, and then purchase the proximal or the anterior C2 body. So that way I tend to reduce my the distraction at the pars fracture level. So that is possible. But then definitely if you want to do an ideal surgery, that is C1, C2, C3 fusion. Because sometimes your C2, just a C2, C3 fusion can fail. If you want to be a failure-free surgeon, then it has to be C1, C2, C3.
Okay, right. So we went and tried a C2, C3 fusion. being a young female, we did not want to include C1 upfront. And I guess these were all options that we discussed with that girl, that, C1, C2, C3 is going to be an option. Doing a C2, C3 with the risk of it being a failure is going to be an option. And this is what we actually achieved following this. And what has happened is actually on the left side, we were able to engage the body. And on the right side, where there is an oblique fracture through the body, the screw has actually pushed the body more anteriorly. And so, in fact, on the right side where the pars is intact, we've not been able to engage the body. And that is causing some amount of displacement on that side. And whereas on the side of comminuted fracture, we were still able to sort of, engage the fracture line and also the body up front. So when you see this scan, after this, my question is, are you okay with this reduction? And I would like to question Professor Kale if he's here. Sir, are you okay with this post-op scan? Neurologically intact patient, C2, C3 has been done. One side the screw is engaging the body and the other side is still not there. Are we okay with this post-op scan?
Well, if you're, can you hear me? Am I audible?
Yes, sir. Yes, sir.
So if you insist on not taking C1, then the only other option is that you do an anterior procedure. But if you're not happy with this, look, the neurological deficit is not going to occur. Whatever had to happen has happened. At the most, what will happen? The C2 body will fall forwards. It will slip down. It will come in front of C3. I have seen these old patients of hangman's fracture who nobody did anything because they were neurologically intact. And what you see on an X-ray a few years later is that the C2 body has slipped forwards. It is lying in front of C3 and it has fused to the C3. And the patient has some problem in swallowing, but apart from that, nothing will happen. So whatever had to happen has already happened. So nothing much is going to happen. But if you don't like these bad looking X-rays, you have to go to C1 to get the alignment all right. Or the alternative is you go anterior and you do a C2-3 discectomy. Then you put something there and then you put a plate in front so that you're sure that, okay, it's not going to slip forward.
Right. So again, sir, I think you've answered the next part of my question as well, that will this patient require a second stage surgery? And I think you've already answered it, that yes, with this reduction, she's going to end up needing a ACDF again. So would you do it upfront or you would wait for some time? Is there any option of waiting and seeing if the fusion is taking place, or should we just go upfront and do it?
You should do it upfront, because if it slips, then the C2-3 disc space is going to get obscured. You won't be able to see it.
Right.
So the C2 body is separate from the posterior elements. It is going to keep slipping forward and downwards.
Right.
So getting to the disc space will be difficult if it slips any further. So you should try and do it immediately. Whatever you can see. Best time.
Absolutely agree. So the more we wait, probably it's just going to get tougher for us more and more. Any interop tips, sir, if you're doing posterior only, to not get into this situation? Any particular tips or techniques in your experience that you would like a surgeon to?
Dr. Muthukumar, we take everybody's comments on this. Dr. Muthukumar, then Guru Raj.
I have a few years.
I think Dr. Parthiban isn't engaged in. Dr. Parthiban.
Yeah, we can go first to Dr. Parthiban. Yeah. So any interop tips and techniques to not get into this situation?
Is he there? I don't think JKBC is there.
Yeah, probably he's not there.
Can you answer the question?
Dr. Muthukumar can.
Yeah. Only interop which Dr. Guru Raj mentioned is when you do an osteosynthesis through the C2, then you have to make sure that you push the exert pressure on the spinous process to obliterate the fracture, so that the two fractured surfaces are opposing each other. And if you look at the post-op scan, you see there's no. One of the problems using a conventional lateral mass screw for this is the conventional lateral mass screws do not have a lag effect. They do not have a lag effect. And because they do not have a lag effect, that is the reason why on one side, even on one side, there's significant gap between the fracture fragments, despite the screw is being in reasonably good position. And that is not going to heal. With that gap, that is not going to heal. And this happened exactly, I think, just before the pandemic. This happened to one of my patients, a 40-year-old lady, neurologically intact. I suggested a second surgery, either going like what Dr. Kale said, either going including C1 or going anteriorly. She said no. And this patient came for follow-up just few days back. Believe it or not, now it has healed. No surgery. But I do agree that is just that is probably an exception, not the rule. But it's preferable always, because preferable always to do a anterior cervical discectomy and fusion, because you are unlikely to make anything.
Right.
Yeah,
Dr.
Guru,
Borkar wants
Guru,
to say something.
what do you think?
So the other thing is to prevent this distraction. The best part is to use a shaft screws. If you don't have a Herbert screw, you can use a shaft screw. And the important thing is to compress this pars fracture is by taking a bicortical purchase, taking a purchase onto the anterior cortex, and take a little shorter screw. And once you take the purchase, you go on compressing it. So if you use a shaft screw, and if your vertebral body can accommodate all the threads, if you cross the fracture line from the threads, so then you will be able to compress it also. So if you purchase the anterior cortex, it will be easier to compress the gap.
Yeah. Dr. Sachin, anything from your end? Any intro?
No, I think what Dr. Guru said is quite right, that that somehow some sort of lag effect should come. And what I have also realized at times, manual drill, if you're using a blunt manual drill, that actually pushes the fragment further. So it should be a good sharp sort of drill, or it can be a mechanized drill, like a AO gun sort of thing, which can engage the distal cortex. That then helps in achieving reduction if you are trying to negotiate that fracture. So what you actually did next was a C2, C3
going
ACDF?
forward, so we discussed this option.
I typically tend to use a high-speed burr, 2 mm or a 2.5 mm high-speed burr, to drill through and through into the vertebral body. Then you enlarge it. So that way you will be able to prevent this pushing of the vertebral body.
Right. So I think Dr. Muthu wants to say
One more tip.
Yes,
I've
sir.
done it once. I've done it only once. That before you start your surgery, you anticipate that it will be difficult to get the two bones together. So one is to push it from behind, push the C2. The second is to push the body posteriorly. So I've even had the anesthetist put cottonoids and gauze pieces in the mouth before the patient is turned over, and have a sponge holding forceps actually going inside the mouth just above the endotracheal tube, so that from below you can push the C2 body up, and from behind you push the spinous process and try to engage the screw. I've done it once.
Yeah.
But it's tricky, it's difficult.
It's tricky, but sounds
you have to do all kinds of things to get the two pieces together. So if you can't push it from behind, you can try pushing it from the front.
Yeah, perfect. Dr. Muthu wants to say something, I think. Dr. Muthukumar, sir?
I think the point which has been made is that manual drilling is going to push the distal fragment further away. I have learned that the hard way. And in such cases, I think it should always be a mechanized drill. It should always be a mechanized drill, because manual drilling will certainly push the fragment away. There is no doubt about it. Of course, the mechanized drill does not give us the feel which a hand drill gives, but then in this particular situation, I think some of my failures were due to the fact that early on I used the hand drill rather than a mechanized drill. So that is a very important point. And as far as that pushing through the mouth is concerned, that should be a good option to reduce the fracture when you do a C2, C3 anterior cervical discectomy. But I would not allow my anesthetist to put my finger in the patient in prone position to put something inside the mouth and take it out. What if the tube comes out?
I know. I know. So it is a dangerous thing, but
I would certainly not
sometimes
allow
you
the
have to
anesthetist to do that.
sometimes you have to think out of the box.
Right. So anyways, we did give the option of the second surgery to the patient, and she was also very clear that she wanted it up front, and follow-up was going to be a difficult option. So we did go ahead and do a C23 ACDF with the iliac crest graft. And so far at 6 months follow-up, the X-ray seems okay, and she seems to be heading towards fusion. And on this, any closing remarks from Dr. Sachin or Dr. Kanwaljeet? Anything more you would like to add to this case?
Very well done. Thank you so much. It was very nice case worth discussing, and it evoked a very good discussion as well. So we end here. I thank all the speakers, Dr. Kale, Dr. Parthiban, Dr. Muthukumar, Dr. Gururaj, and all my colleagues and the audience who participated, asked questions. I hope it was useful to all of you. And I thank ASSI as well as the Neurological Society of India on collaborating on this complex topic. And hopefully we will have more such collaborative webinars in future. Thank you very much and good night.
Good night.
Thank you. Thank you. Thank you.
Good night.
Thank you. Bye-bye. Good night.